Good morning. I'm now presenting our work about chorioretinal atrophic lesions evolution in patients with quiescent myopic choroidal neovascularization followed for more than 10 years. I'm sorry, this is out. Pathological myopia is the commonest cause of choroidal neovascularization among young patients, and even after successful treatment of active lesions, myopic maculopathy continues to progress with the development and increase of chorioretinal atrophic areas and progressive visual loss. The purpose of this study was to assess the evolution of these chorioretinal atrophic areas associated with previously treated myopic CNV lesions in patients over a long follow-up period. This was a retrospective single-center and observational study that included high myopic patients who had at least 10 years of follow-up and myopic CNV lesions that achieved clinical and structural remission during this period. Medical records were reviewed for demographics and CNV lesion classification, and we determined best corrected visual acuity in 3 different time points: BCVA before the first treatment, immediately after the last treatment, BCVA1, and at the latest visit, BCVA2. We used fundus autofluorescence to quantify the atrophic area associated with the previously treated myopic lesion, and the first exam performed immediately after treatment suspension was compared to the most recent exam, and the amount of the atrophic area increase per year was determined, as well as its visual impact. 36 eyes from 36 patients were included in this study. The mean age was 62 years old, 72% of the patients were female, and the mean spherical equivalent of the patients in this study was almost minus 12 diopters. Regarding systemic comorbidities, the most common ones were dyslipidemia, systemic hypertension, and hypothyroidism. Almost 90% of the CNV lesions were classic, and 75% of them were subfoveal. Each eye was treated with a mean of 12.5 intravitreal injections, both bevacizumab and or ranibizumab, and in addition to the anti-VEGF treatment, 25% of the eyes had previous treatment with photodynamic therapy, and in these eyes needed significantly less intravitreal injections when compared to the patients that did not receive PDT. The mean improvement between BCVA1 and BCVA0 and 1 was around 5 letters. However, a drop of 8 letters was noticed between BCVA1 and 2, so a higher decline in visual acuity associated with the atrophy when compared to the visual gain associated with the treatment. The final BCVA2 was worse in patients with higher atrophic area growth rate. The initial FAF1 was 6.3 millimeters square and increased to 9.8 millimeters square at the latest visit. This corresponds to a mean individual variation of 3.5 millimeters square per eye in a mean time of almost 5 years of follow-up. So the mean growth rate of the atrophic area in this study was 0.89 millimeters square per year. Larger FAF at the baseline significantly correlated with a larger FAF2 area at the final visit, and also with a higher growth rate of the atrophic area. Eyes treated with PDT, despite needing less intravitreal injections, as I mentioned before, had larger FAF1 and FAF2 areas, and hypothyroidism was associated with a higher atrophic areas growth rate. So this research highlights the importance of chorioretinal atrophy progression after myopic CNV regression and its impact on visual prognosis. It also identifies risk factors associated with the development of larger atrophic areas and ultimately worse visual outcomes, such as previous treatment with PDT and hypothyroidism. However, further studies are needed to better elucidate and establish the risk factors associated with this event, this chorioretinal atrophy progression, its pathophysiological meaning, so that we can shed some light on the preventive mechanisms associated to prevent this silent but devastating progression. Thank you.
Thank you. We're going to pass to the second, the further presentation. Yes.
Yeah. So the next speaker is Dr. Flores Moreno from Spain, talking about the relevance